Hi, everyone. Welcome to the Sports Docs podcast. On each episode, we chat about advancements in the field of sports medicine with experts from around the country. Today, we're coming to you live from the 10th Annual Arthrex Team Physician Controversy Conference in Naples, Florida. I'm Dr. Ashley Bassett.
And I'm Dr. Catherine Logan. The Team Physicians Controversies course is a 2-day conference that brings together experts from around the world to talk about patient diagnoses, treatment plan, as well as return to sport. We are lucky to have a lot of these experts here with us today to talk about all of their expertise.
So today we're talking about the management of ulnar collateral ligament injuries in throwing athletes. And we're joined today by two outstanding guests who have extensive experience treating high-level throwers from adolescent pitchers to elite athletes. Dr. Neal ElAttrache is an orthopedic sports medicine surgeon at the Kerlan-Jobe Orthopedic Clinic, where he's chairman of the board of the Kerlan-Jobe Orthopedic Foundation and program director of the Kerlan-Jobe Fellowship. He is head team physician for the LA Dodgers and LA Rams and is highly regarded for treating elite professional athletes.
And Dr. Jeff Dugas, he's an orthopedic sports medicine surgeon at the Andrews Sports Medicine and Orthopedic Center. He is the program director of the American Sports Medicine Institute Fellowship. He serves as medical director for USA Cheer and associate medical director for the WWE, and also provides coverage to college and high school athletics. He's published extensively in the field of ulnar collateral ligament injury and surgical treatments. So Dr. ElAttrache and Dr. Dugas, we're super excited to have you here. So welcome to the show.
Great to be here. Thank you.
Thanks for having us.
So today we're going to focus on treatment decision-making and the different surgical techniques for UCL injury, which have really undergone a dramatic evolution over the last decade or so. But before we do, we want to set the stage. So Neal, what are you seeing in terms of UCL injury patterns and how these injuries are being treated? And what do you think is driving this?
Well, it different in the different populations, but the population I see, the style of pitching and the demands on the shoulder and elbow now are different than when I started taking care of these guys years ago. The maximum effort in velocity and maximum effort in spin has produced a really unique sort of new injury pattern, and so no longer are you only need to be concerned about the ligament, but the tendon interface with the ligament, the conjoint tendon, the deep raphe of the conjoint tendon, and both if it's partially injured at the time of surgery, or if during the surgery to approach the ligament, you're not paying attention to how that raphe, the deep part of the tendon, interacts with your new graft. That's often a site of the beginning of pathology post-op too. So, the short answer to your question is the style of pitching has become much more demanding, much more violent, and with maximum effort and maximum potential for problems with basically every pitch, whether it's velocity or spin.
Absolutely. And we're going to talk a little bit about treatment to get going there. But let's start with partial UCL tears. So Jeff, are you typically starting with non-surgical management for partial tears? And, does the location impact how you think about this?
So yes to both of those. And I think partial is a really big number. It's everything from a little bit to a lot. And so partial is not really, that easy to ferret out. And MRIs are just MRIs, and some MRIs are better than others. And so I think you really have to assimilate information and make sure we're not treating the image. And I always say this, treat the person, not the image. And you really have to ferret out where the problem is, how much of a problem it is, and how much of it is real and how much of it is new. Sometimes we see these people and they've had maybe that partial, quote unquote, partial tear existed for a long time. Maybe you disagree with the radiologist. And does it make sense? And where is their pain? And really get a good exam. And is the pain where the imaging says it is? There's no question that partial tears proximally are a little bit easier to treat non-surgically. There's more blood supply. So the idea of whether it's PRP or some other biologic injection has a little bit higher potential proximally. The distal ones do not respond well to that. And timing of the year makes an enormous difference. We know what the return times are from the surgical perspective. And so do you have time in your seasonal timeline or your career timeline to make that decision to treat them non-surgically, or do you need to make a decision? So those things play into it. So it's really an assimilation of all of that to really make a good clinical decision for the person.
Yeah, and you mentioned PRP there. We do want to talk about that a little bit. So we know non-surgical treatment usually involves a period of rest from throwing, structured rehab, but PRP to augment that treatment has been discussed. So Neal, where does PRP fit into your algorithm for non-surgical treatment of UCL injuries?
Yeah, if you have the time that it will take for PRP to be effective, both on the front end, because right after you give the PRP, it's not like it's a magic bullet where they're going to go out and they're going to start to pitch again in a couple weeks. So you have to have time on the front end to let it work, and then if you have time in the player's year to go through the appropriate amount of time so that if you are stimulating a healing response, and then to get them going, and then you have to consider the time for potential failure. So if it doesn't work out, where are you? And has he lost now a second season? Which would be the kiss of death for a guy that hasn't established himself. So that's where a little bit of taking care of a team athlete comes into play, because you have to, like Jeff said, you're dealing with the whole human, but you're dealing with the whole perspective and place he is in time in his career. And so sounds like a complicated answer to a simple question, but
That's good.
But PRP is helpful for trying to stimulate a healing response in tissue that has a good chance of healing. And so there are some attritional tears that you got no chance. But if it's a partial tear, biologic tear, one that I sort of like, it would be a younger player. Two scenarios. One would be like a younger player who doesn't open much on stress views on an MRI scan, the so-called fever view, but has some pathology in the ligament. Better if it's at the top of the ligament than at the bottom of the ligament. I don't see PRP working very often at the bottom. If it's peeling off at the bottom, and then they have the time like we talked about. That's one. The other is the older pitcher who's trying to squeeze out a little more time in his career and may not have the time left to go through a more lengthy surgical procedure, whether it's just a repair or a reconstruction, and to try that because once again the tendon's involved, and I think you have a higher yield when you have a combination of tendon, ligament, or tendon problem than just ligament.
I agree.
Yeah, absolutely, Neal. I think that's a great answer. And, PRP is promising for the right candidate. Like you said, it's going to depend on the tear. It's also going to depend on the athlete themselves. But what about these complete tears? Jeff, do complete tears always go to surgery, or how do you handle those?
I don't think most complete tears are going to heal. And we can't expect that thing to crawl back down there and reattach itself. And, when we talk about complete tears, you see gymnasts and tumblers where they effectively dislocate or have an almost dislocation event. That's where the ligament is literally, the whole thing is torn off. You really don't see that in throwers as much. A part of the ligament may be completely torn, but you're not going to see the whole thing flapping in the breeze like we do with some of these grappling or tumbling athletes. So those areas where it is completely torn or it's really high grade, whether it's proximal or distal, I think they're facing an uphill battle with non-surgical management. We can do it and there can be success, but we have to tell them it's likely that this is going to come back. You may get back, but it's not likely you're going to go on and have a career that doesn't involve this problem. And it gets back to that timeline question, the career question, where are you? And unfortunately, the younger they are, the less timeline tolerance they have. You can't get a year of high school back. College, you can get 1 year back. And pro, you may have a 4-year contract and you're in year 2 and you got 2 years. So there's a different time tolerance to these things that people have. And you have to respect that. And, fortunately or unfortunately, we've kind of created this problem with operations that have really high success rates. So people are unfortunately not afraid of this. And it's a great thing, but it's also a terrible thing. People have no fear of this operation. And it's not necessarily a healthy approach. And we have to be more objective than that. But I do think that we feel confident in these operations and making decisions in timeline and they're where they are seasonality wise and what their goals are and what their opportunities are. And if they haven't had the opportunity yet and that's what they're seeking, we can't look at them and say, oh, you can't pitch. We have to try to give them that ability to achieve their goals. So I think the complete ones, you're probably better off just making it happen.
Well, that segues really well into our next discussion, which is to talk about the different treatment options surgically for complete tears. So historically, reconstruction was the default, but there's now much more interest in UCL repair, specifically with internal brace augmentation. So Neal, can you tell us, what do you think shifted the paradigm from reconstruction towards repair?
Well, I think that relooking at how repairs actually did historically, compared to reconstructions, repairs historically never did as well, but they didn't always fail. And I think that you need once in a while with pretty much every surgical technique that as it becomes refined and you learn more about the anatomy, maybe it's helpful to go back and review what you used to do and how you used to do it and say, well, maybe it was failing, maybe because I just wasn't doing it as well. I wasn't. And so some of it was that when we learned more about the anatomy and exactly how to fix these things. And then equipment too, here we are in Naples, Florida, and I'm going to put in a little plug for, Arthrex always responded to what a surgeon needed rather than handing a surgeon an instrument or an implant and saying, figure out, where this works best or how to use this. And so, as we started to be able to understand more, but we didn't have the tools to fix it in certain places. A company like Arthrex, they built their whole business on providing that opportunity. So implants became better, the approach became better, our knowledge of the thing became better. So I think that we revisited why were the repairs not so good, and I think that then it became obvious that just like what we're seeing with ACL and PCL injuries and ligaments elsewhere in the body, if the ligament overall is biologically healthy, but it's torn off, that ligament has potential if it hasn't retracted and sort of become too short, it won't reach its anatomic position. That ligament has a good chance of healing if you put it back properly. The problem is a lot of the repairs that we would have had to do in I'm a bit older than Jeff when I was starting with when Frank Jobe was teaching me about the UCL and how to reconstruct them, those ligaments were blown apart because there was nothing left,
right?
And a lot of times there was just a piece of bone left in there, or when you got a stress view of the elbow, it opened up a centimeter, and so those were. There's no chance that you can repair a ligament that's been through that, but we're making the diagnosis earlier, where a lot of these are a ligament that biologically is pretty darn good, but it's failed at one side or the other, and so I think that it lends itself then to go back and review: were we really doing this well enough? And the other thing that really I think realistically changed and pushed towards trying to repair a lot of these was Lou Yoakum there was a stretch of time where he was having some the first population of guys that had a Tommy John done and then they were playing long enough that then they were failing. Frank Jobe and Jim Andrews at the beginning, they weren't seeing a lot of the failed Tommy Johns because the guys that they were doing were older guys. And so, it wasn't like a guy was having a Tommy John as a minor leaguer and then coming back and playing. And he's not bulletproof. He's got the same chance of having a UCL tear during his career as anybody else. And so, he's getting it young. He's going to play a long time. So at some point in his career, there's a chance he's going to have it. We started seeing those guys. And so, when Lou had me take a look at some of these and try to figure out, what do? We put a new graft in, and right around 2012, I had a couple people that he had sent me that I saw that the graft was great, and they would always fail right under the epicondyle, right where they call it the bending moment is, and I would look at these MRI scans and I would know what I was going to see when I got in there. The big robust piece of tissue that was really well anchored on the sublime tubercle. Well, how can I make that better by, ripping that apart and drilling new holes and it was just seemed like too good a piece of tissue to think I could do that better by putting another graft in. And so I started repairing those in 2 layers. So I wouldn't just repair it in one layer. I would go deep where I felt like the ligament was, because once again, I was learning more about the anatomy. And quite frankly, when Dr. Jobe and Dr. Andrews were doing these, they were putting the ligament far more medial than where the ligament goes.
Right.
It was working for a different reason, but
Right.
They were hesitant to go because they were putting big drill holes in to go, where we put them now. So I was going deep and then superficial once again because I had now new implants that I could do it, and the first 2 that I did, worked. And the guy got back into playing in the major leagues and without putting a new graft in. So then speak to guys like Jeff and Andrews was still doing stuff, and I showed him those cases, and so and then Buddy Savoie revisited the whole issue about repairs and looked back on it and reminded us all that, hey, by the way, in the first paper that Jobe wrote with John Conway, there were some repairs in there and they didn't all fail. And so he went back and so there was that series of events happened within the span of maybe about 3 years or so. And then people started to take a look and see, is there a role for repair again in this? And so combination of technology and then relooking at what we were doing and why it may have worked in some and not in others. And so, but it's led to, Jeff has a huge series of repairs of ligaments, and it's really been a very helpful thing for this explosion of injuries in young kids. And so I think we are where we are because of all those things.
All those things.
Yeah. I think, Neal, it's always, as you said, very helpful to reflect back and look at our history and say, what really was the truth and how can we learn from that and evolve, and also partner well with industry to say, we need this and we need to evolve here so we can sort of change our technique. But we want to go a little bit farther into techniques for both repair and reconstruction. But before we do that, Jeff, you were an early adopter of the internal brace. We want to talk a little bit about that as a clinical innovation. And, were there any early indicators for you that said, this is, a technique that I want to adopt and why?
Well, Neal said it great. All those names, those people, the giants, Jobe, Andrews, Yoakum, Buddy Savoie, Neal ElAttrache. These are people who have amazing clinical experience with these things, and they had failures. The success rate of repairs in those original 2 articles by Andrews and Jobe was about 30%, but they didn't all fail. But they didn't have super sutures and tiny anchors and the knowledge and experience of where to put it, how to rehab it, all these things. And so what started all that And we all talk, we're all friends. We all talk, we share patients, we communicate very well. And Andrews, we were doing cases. Lyle Kane and I were doing a lot of cases with Andrews as we were in the kind of early years of our career. And Andrews would say, it's a shame we got to do this big operation for this little bit of problem, this little tiny bit of problem in this kid. We got to do this big 12-month operation. We got to figure something else out. Well, that was about the time that Gordon Mackay, the foot and ankle surgeon from Scotland, had come up with the internal brace. And it was two plastic anchors with a fiber tape. And he was doing it in the ankle. And so I called down here and I said, I think we can do this in the elbow. And I spoke to one of the engineers and they said, no, it's too small. The anchor's too small. We won't be able to do it. I said, can we try? We don't think it's going to work. I said, let me come down there and we'll get a cadaver out and I think I can do this. I think this will work. So I came down to Naples and we got in the lab and I showed them that I think we can do this. And the next thing you know, they're talking about how this is going to replace Tommy John surgery. And I said, no. This is going to help for some. And that was really kind of the key. And through this whole process, I'm talking to Neal and Buddy and Mike Siccotti and people that do George Paletta and these people that do Keith Meister, these people that do a lot of these things. We're collaborating. And I remember Neal's comment as we were going through this. We were at a meeting and I was talking to Neal about the idea and we had talked about it before. And he said, I think one of the best uses of this is going to be in revisions, because revision Tommy John surgery is probably one of the worst operations that anybody does, that with a success rate of maybe around 50 or 60%. And we were still doing it. That's not our typical world of sports medicine. And he was the one who said, I think this is really going to change the game in revision settings. And so I got a lot of encouragement and support from my colleagues to push this. And we wanted to do it the right way. So we came to Arthrex and we said, look, we need to get some studies going and look at this at time zero, do some basic science studies. Because before we do this in a person with a pulse, in a human, I need to know that this is at least as good as what we're doing every day with reconstruction. So we did a couple of basic science studies that Arthrex was good enough to fund. And we showed that at time zero, when we put this thing in there, it was at least as good at resisting gap formation. And it wasn't to show that it was better. I just wasn't going to feel good about doing it in a human if it wasn't at least as good. And it was. And so the first patient walked in and we did it. And I did 4 of them and I waited 6 months. And I wanted to see what happened before I did any more. And then the next year I maybe did 10 of them. And now we're doing hundreds of these things, and we're finding that the combination of the quote unquote hybrid, I use that term loosely because there are about 15 different versions of the hybrid. So the hybrid is hybrid. But using some form of augmented reconstruction or repair or reconstruction, knowing where all of those things fit and who they fit for, those are the things that us as a colleague group really are trying to understand and continue to talk to each other through what our successes and failures are. And I can't say enough how much this is more of a we thing than a me thing. I didn't come up with this in a vacuum. This was very much driven by colleagues that talk about these things and want to see the science get better and the clinical outcomes get better. So there are a lot of people that deserve credit for that. And Neal's a big part of that. I can remember a lot of the conversations with Neal and
I was trying to referee between you and Jimmy.
I know. Andrews was telling me not to talk about it until we got to a point. And
you're presenting it for your first several, and Andrews he's doing this to himself in the back row, and he said, "Come in." He wanted to tell you, he says, "What's happening? Is it? What do you think? Should I tell him to tone it down?" I said, "No." I said, "You gotta let this play out." I said, "There's a role for this," but I was trying to help things for you.
I'm out there getting tomatoes thrown at me by some of these guys, and Neal and Mike Scott and all these guys are like, "No, just this is a good thing. We're on the right path. Just be patient. Just let it play out. Don't talk about it as the next coming." And we never have done that. Yeah. But we have never one time said this is better or should replace, or it's another option. And it makes sense for a fairly large segment of these things, because like Neal said, we're not seeing these old blown out ligaments
Right. Yeah.
as often. We're seeing these young people with these not as big injuries, and it fits some of them. It's not a panacea of everything. And but the technology part of this, what Arthrex did, has really made a difference, and they are good at that stuff, and they responded to the need and made it happen. So a lot of credit to them.
When were you guys residents? What years?
Graduated
I'm sorry,
2012 was
2012.
when I started. So,
2013, finished 2018.
So just think of 12 years, 14 years. Think of, are there any techniques that were done then that are done the same way now? Can you think of any? The most common things are they're done differently,
right.
and there's a lot of reasons for that. When we were dealing with what we're talking about, part of the reason was because we just weren't able to keep up with the newer and newer demands of the patient. And so as the demands started to run away from us and we were still doing things the same way, pretty soon, we were seeing, okay, well, this is working, but it's not durable. It's not holding up. And so we had to be honest and address, our failures and why is what we're doing not good enough? And it was the demands of the patient were exceeding the older techniques that we would have been doing, 12, 14 years ago. And so to enhance it with taking what Jeff and some of the guys did early on with the repairs, and to take that technology and to then advance what we were doing with the reconstructions and to enhance that, that helped address the newer and bigger demands that they were putting on our reconstructions. And so one great piece of work led to, being able to solve the other problems. And so, when I look at now, the whole philosophy of load sharing the load that your graft or your repair is going to see with a something that's not going to stretch or fail while the person is rehabbing and getting back to what he's going to do. That's the beauty of doing that. It's not that the new repair suture and the internal brace is going to take the place of your ligament or your reconstruction. It's going to share the load so that, all you have to do is go to your favorite trainer or therapist and say, hey, listen, what do you have to do to my patient, your player, to get them ready to play after my surgery? If you want to learn about what your reconstruction is going to go through, get to know what they're going to do in the training room. And a lot of times in the training room, they've got blinders on and they're just looking at, okay, how am I going to get this guy's motion back and his strength back, and he's going to get back out there and the coach is going to be happy with me. And they're not thinking about, wait a second, there's a biologic maturation time, and and so real quickly you find out that those two processes don't match. And so you say, oh, well, now I know why they stretched out their Achilles repair or in this case, the ligament, because the demands were too great before the repair of the reconstruction was mature. And so load sharing protects the patient's tissue and protects the surgeon from the necessities of what it takes to get a guy back to sports,
100%.
So.
Awesome. Well, that was a really nice review of not only the history of internal brace, but how it impacts the surgery biomechanically. We want to talk a little bit about clinical outcomes. So, Neal, you take care of a lot of MLB players. In terms of the internal brace, how has that changed, career length, contract renewals, speed of return to play in terms of what you were doing previously?
Well, it's definitely had a big impact. And I think that Jeff touched on that earlier, the confidence that the baseball world including the baseball world that has a checkbook, they have in what we're doing now it's a little scary. I can tell, but it's public information. I mean, Shohei Ohtani was given a $700 million plus contract, guaranteed, and that contract was consummated about 6 weeks after I did a revision Tommy John on him. At the time that the published literature on a revision Tommy John was the old literature that Andrews and Yoakum and you and I wrote, that was showing that, okay, well, you're going to have about a 30% chance of this working out. Well, but what the baseball world knew was that that's not where we were anymore. We were way beyond that. And so, it's impacted careers, and it's impacted the entire sport in a huge way, because now you have something that would have been considered career ending, and guys winning MVPs, and this is not just for him, but you think of all the great names that are going to end up in the Hall of Fame or whatever, because they've been able to come back and play long enough to be able to achieve their goals and the team's goals or whatever in the sport. And so, the advance of technology and surgical knowledge and outcomes has changed the sport. And I don't think that's no way an understatement. It's had a huge impact.
Yeah, and we're now seeing, people getting drafted, high in the draft, coming out of either high school or college with this, technology in their arm, whether it's just a pure repair or it's a hybrid, or
they don't even fall out of the first round.
Yeah.
And when they know that the guy needs a Tommy John next week, or has just had it, they don't even
pretty
fall.
incredible.
They're not scared of it. And the return to play rates in the most recent paper we put out, it's in people who attempted to return to play, all the way from high school to major league, was 98 and 99%. And it's just, I don't think it's necessarily healthy not to have a fear of it, but we can't argue the success rates. And that's not just us as the surgeons. It's the PTs, it's the athletic trainers, it's the organizations, it's the understanding of the operation and the process, and how it differs from person to person with their demands and position to position, and all those kind of things that adds to that success rate. I think that we as clinicians have done a better job educating and sticking with things and working together. And I don't think that the front offices of Major League Baseball have the concerns that they had even 5 years ago about these things. And the wide acceptance of it is due to the clinicians and working with the teams and the team of people around these players that adds to that success. So it's not just the surgery itself, it's the whole understanding of the whole medical team around these people.
Agree. I think, the outcomes have become quite impressive. And Jeff, you've published extensively on UCL, especially repair. So we want to dive into, you mentioned your publication last year in AJSM. If you could talk a little bit about outcomes you're seeing and how do you decide between repair and reconstruction?
So in my hands, like Neal, I'm seeing a spectrum of people from high school to major league, and my population I'm not tied to a team in major league. We're independent at Andrews of any of the major league teams. So I tend to see a lot of college and high school kids in addition to some of the pro guys. I think you treat it as the pathology dictates. I don't think it's a one size fits all experience, and it's a shared decision making with the player. I'll have pro guys that are about to hit a contract year, and they're 28 years old and they're in the middle of their career, but they're in a contract year and they have to pitch and they can't miss 2 years. It's like Neal said, 2 years out is the death nail for some of these guys, or they're a position player. And so again, it comes back to that timeline question. Is this, I always say there's kind of 3 criteria to do a repair, just a repair. You have to have good enough tissue to repair. It can't be crappy tissue. It's got to be good, healthy ligament tissue. It has to be an end injury. You're not going to repair something in the middle. I don't think that that's going to hold up. And there have been some successes with that, but I think on the whole, that's probably going to fail a little more often than we want it to. And I think the third criteria is you have to have a time benefit of a shorter recovery. The GOAT is the GOAT for a reason. And I say that phrase a lot. Reconstruction didn't get to be the GOAT by accident. It is still the GOAT. So if you don't have a shorter timeline, why would you not have a reconstruction? Plus minus the augmentation. You need a graft. If you have tissue deficiency, you need a graft. If you have a middle injury in the middle of the ligament, you need a graft. But if you don't have those things, you meet those criteria, the repairs have done very well. And I think that if you stick to those criteria, and that's something that we have dogmatically stuck to since the beginning of this, and we have said also, do not max tension this thing. The ligament is the ligament. The augmentation is the augmentation. The augmentation, the internal brace, is not the ligament. If you over-tension this thing, you can have some issues. So you need to put it in as a supportive structure, not as the ligament. And so I think if you follow those kind of guidelines, that the outcomes are going to be, you're going to get the same outcomes we did. And so we published that article last year in AJSM, and Brett Owens was so kind to us in his editorial. And I can't say enough how much I appreciate his kind words, but the outcomes were really good. And I think that it's because we stuck to that. And as we all talk about these things, and I keep saying this, we talk about these things a lot and we work together. I think that that's all part of it. It's not like Jeff's rules or, Birmingham's rules. We came up with these things together. And I think as we all stick to these things and we keep pushing it with these different versions of hybrid, and we need to figure out where those augmented reconstructions, what versions of them work where and better and in what patient. And we haven't really that's kind of the next phase of this is how does the hybrid work best? What are the things about doing a hybrid reconstruction? What are the fine points of that change the outcomes in one player versus the other? And that data is coming as we continue to grow that. But we just have to keep pushing it.
So now we understand who to operate on. Let's talk a little bit about technique. I'd like to hear from both of you, but let's start with Neal. So what is your surgical technique for repair? What implants are you using? What approach are you taking? Any tips or tricks for surgeons doing this surgery?
I do maybe only a handful of only repair where I'm not using it as a hybrid technique. In throwers, I do a lot of repair in non-throwers. Football players, if they've torn their ligament and the conjoint tendon, those are ones that don't predictably heal well to get their stability back. Wrestlers, anybody who's going to be weight bearing, especially if they've got damage to the flexor pronator tendon. I'm repairing those. The population of guys and kids that I would be repairing would be the same as Jeff, and works best distally, and that long shingle of attachment distally on the sublime tubercle and ulna, it lends itself better to more predictable healing and tensioning is perfect on that side. And so that's where, but the way my practice has evolved, I'm seeing less of those patients and more of the older patients, so the repairs for me are in the setting of the revision setting. And we can talk a little bit about how I put the stitches in when I'm doing an augmented reconstruction or repair, but it's a little bit different. But the population that Jeff has really exposed the widest has become a little bit smaller in my practice.
Yeah, I would say for me, I'm still doing the pyramid. The base of my practice is younger throwers, high school, college, across all segments of college. We're the team docs for couple of SEC teams, a bunch of Division I colleges. So we deal with some pretty high level throwers that all want to go play, pro ball. And I think the decision making, again, is based on the pathology they have. I have a low threshold for reconstruction. And I generally consent people for both a repair and a reconstruction because I don't have faith in MRIs to solely make that decision. And you have to see it and feel it. You have to look at it and know where the pathology is and what the tissue looks like. And if it's good for repair and the patient is up for that and we've had that discussion, and most times they say, I want the repair. I tell people, if you tell me you just want a reconstruction or a hybrid, I have no problem with that. Done. Cross repair off the list. If you tell me all you want is the repair, I tell people that's a bad decision. You have to let me see it. You don't want me repairing poor tissue. You don't want me repairing something that really needs more collagen.
See, I think that's important, and I need to say that. Jeff is in a position where he could tell these patients and these families, let's do a repair, and they're going to do it because they're coming to see him because they know that that he's known to do a great job with these, but Jeff is being honest with them and not saying, well, it's up to you. He'll make his recommendation, and if he doesn't think it's the right thing, he won't even offer that as an option.
Right.
And he'll say, I know you came here because you heard that this is what I do. But I think that it speaks to why this has been so successful relatively quickly is because, people like Jeff are offering that as an option when they really believe, based on the work they've done, that's going to work. And so that's what you've done and how you've handled is why one of the reasons that it hasn't fallen by the wayside.
Well, and the adoption by all of you and John Conway and all the big elbow docs that have found the places in their practice where it fits. I don't have an ego about this. As this was never supposed to be replacing something. It's never. I never looked at it that way. Andrew's challenge was to come up with something for some of these, and I think we've shown, and I believe that we've done that, and I'm proud of all of us, not just me, all of us, making that happen as a profession, as a clinical group of people that see these things all the time, and seeing other people have success with it. I think you still have to have that. Where does it fit mentality? Because it doesn't fit all of them. In fact, in times it doesn't fit many. I'll go through periods where I'm doing 80% reconstructions and times where I'm doing 80% repairs. And it's just based on what that individual has and needs. And I think it's unemotional and just you have to see it and understand the pathology.
Yeah. And, Jeff, while it certainly is a community and, we know you've share with your peers and you talk, but obviously we want to hear about your technique and share your surgical pearls.
So I agree with Neal. The distal ones are much easier for repair. You have a pretty easy access to the joint. You can make sure you're putting your anchors in the right place. The sublime tubercle is a very identifiable landmark. And I think basically every ligament in the body has a pretty easy to identify end and a more subtle insertion. I think that most UCL surgery, if you had to pick a place where things go poorly, it's the medial epicondyle side. The ulnar side is pretty easy to identify. And whether you're drilling tunnels and putting a graft in or you're putting an internal brace in, it's more identifiable. So I think the rubber meets the road in these things when you deal with the humeral side. And having a clear understanding of that anatomy and where that thing is and how to gain isometricity and how you go about that process in the operating room to know that you're putting the thing in the right place. So it starts with your approach. It starts with where you split the ligament. We all try to split the ligament right in the middle and make sure we're not too posterior, too anterior. We're not getting fooled by surrounding tissue. So I think exposure is key. Whether you move the nerve, whether you go through the muscle, under the muscle, how hard they throw, how old they are, where they play, what position. None of that stuff seems to matter in terms of the outcomes. But I think that's because we're not doing these things in people. You have to do the right operation. So I think if you stick to that, those things aren't going to matter. It's like Neal said, the biology of ligament healing is pretty robust if you have good ligament and you can get a good insertion. So we always freshen the bone. On the ulnar side, I use a rongeur and just freshen the bone up and put the anchor in at the apex of the sublime tubercle and sew it down. And then I close up the split and put the anchor up on the humeral side. On the humeral side, I've gone to using a burr and actually holding the ligament open with a hemostat and taking a burr and creating biology there. Because I think that is less robust and less, even though there's more blood supply, I think that's where most, if you had to decide which side of the coin is more of a problem, the humeral side's more of a problem. So I've gone to using a burr and just kind of not decorticating it, but just making it bleed a little bit before I put that anchor in, and really checking the isometry through a full range of motion before I sink that second anchor in there and advance the anchor and create the internal brace construct. And so it takes a couple of seconds, but it takes a lot of experience to see that and feel that how it's supposed to work. I would rather put it in a millimeter loose than too tight. I think over tightening is going to create some problems, has created some problems. So I think these are all kind of the principles. And I always put the first anchor in on the side of the injury. So you're repairing it, which is what Buddy did in his articles back in the mid-2000s, and what Job and Andrews and Yoakum did. They were sewing these things back. So I think it's important to do the first anchor on the side of the injury, on the end of the injury, and then the second anchor on the opposite side. But creating a good biology for healing, you're ultimately trying to get a piece of tissue to heal the bone. And creating that environment is important. So I don't think you just throw an anchor in and sew it down. You have to create biology.
That's a great overview of repair. We do want to wrap up today with talking about reconstruction briefly. Obviously, it's advanced a lot since the original reconstruction in 1974. So, Neal, could you speak about how your reconstruction technique has changed and what are you currently doing?
So I use the philosophy of load-sharing suture. And by and large, if I'm going to do a reconstruction, make my drill holes in the sublime tubercle the same way that we've always done it, become much more precise on where, if I can just a little surgical tip for those of you that are out there, learning about how to do this. Don't try to estimate the center of the sublime tubercle. Find the medial ulnar ridge. It's always present. It's distal to the sublime tubercle, and it's a sharp, identifiable ridge of bone. And the way the good Lord put that in and lined it up, it perfectly lines up with the long axis of where the center of attachment for the ligament is on the sublime tubercle. I learned that over the years because the sublime tubercle can be shaped in a lot of different ways. Can have a big spur coming off the posterior side because the posterior band of the anterior bundle is the one that is going to be under the most tension. So, when you have a big sublime tubercle osteophyte, it's not going to be in the center, up the center fiber. It's going to be more. So if you're looking for the center of that sublime tubercle, maybe it's been cracked before. It's going to be a lot of different shapes, and you can have a good reconstruction go bad because you're a little bit too anterior, because that's where you thought the center of the attachment was.
And the same for repair. You have to pay attention to that because you're putting a linear something in there. You have to pay attention to that.
So
that
simple surgical pearl is find the medial ulnar ridge and extrapolate a line straight proximal. That's going to take you right to the center of where you should be, and then span that center of attachment with your drill holes. And so that's the ulnar side. If the ligament is good quality all the way up to the proximal end, and that's where the failure was, then I put my hybrid sutures in the native ligament. And so I will have split it in the central fiber, and so that I can see the joint, put my graft in, and then before I pull my graft up into the epicondyle, I take a braided suture, and I then shoelace that ligament up, the native ligament, and I put the graft deep to that because that's where I want that interface of. There's a great new anatomic study that I don't know if it's even been published yet, but I saw the manuscript. It's a histologic study that shows that there is true interdigitation of the deep raphe of the flexor tendon with the ligament. We always knew that there was some biologic origin of the flexor, but this is the first one to show that the actual tendon and ligament blend right at the epicondyle. So I like to keep that interface pristine. I don't like to destroy that. So I put my graft underneath that into the anatomic place on the epicondyle, and then I pull my shoelaces tight, and I pull the suture with the graft up into the epicondyle. And so then the first thing I do then is I pull that and I tie the native ligament tight. So now I know I'm anatomic. I know the sutures, those load-sharing sutures, are going to act exactly when they're supposed to. There was a study out of HSS that showed that if you're even, a millimeter or so out of the footprint with your internal brace, it's either going to capture the motion or it's not going to function when you need it. And so, having it in there, that I know that it's going to share the load that's going to be my anchor, basically my distal anchor. If I don't have good tissue that I can count on that being my anchor, then I put the swivel lock in down at the sublime tubercle. Now you can even use
between the ulnar tunnels and the joint.
Right.
Mm-hmm.
And there's enough. It takes a little experience in playing with that, so that you know exactly how you can put that in without drilling into your graft in the tunnels. But there's definitely a lot of room, and you can do it with a little bit of practice. But and I have a pro pitcher that is coming back this year that had a big sublime tubercle osteophyte that was actually almost touching his epicondyle, but with maximum flexion and extension, it was limiting. And so you can't really put a graft in that situation without whittling that down. But when you whittle that down, now you got a big hole. You got nothing. And so I try to spare some tissue there. And in that one, I put an internal brace right up the middle where that big hole used to be, so that I had something to imbricate and sew together. But those are just little tips on how to do it. But putting the stitches in the native tissue, and so you're killing two birds with one stone. You're repairing the native ligament, and you're anchoring your stitches in that are going to load share and do the function of the internal brace, the hybrid.
Yep.
Yeah, Neal, those are really helpful surgical pearls. And, Jeff, do you have any additions as far as your graft choice or fixation choice?
I think we probably do them very similarly. I do the same thing. We're using a suture tape for it's a braided tape for the repair of the native ligament and tying it on the medial epicondyle. Like him, sometimes I'm using an anchor. I may use a soft anchor instead of the swivel lock. Sometimes I'm using a fiber tack. 1.9 millimeter fiber tack. I sometimes I'll do both. I'll because some of them are double loaded. I'll use some of that to repair some of the tissue down and run the sutures up the native ligament. So again, I think it's kind of a a la carte menu thing. I think it starts with, if you're going to be a UCL surgeon, I think you have to know how and where to drill your tunnels, and you have to know variable anatomy. You have to be able to get exposure. You have to have your team. You can't do this with just one person or two people. You need a team of people to do this and do it well. I think this would be a hard operation to do with just two people. So having a team that is familiar with this and doing it facile, this shouldn't take 2 hours to do. You don't want to have a tourniquet up on one of these people for 2 hours. And So I think all of these things make a difference. But I think with practice, people get good at this, and they should. They should keep practicing it and keep reaching out. We get calls from surgeons all the time asking these kind of questions about technique and variability and things, and we welcome those things. We're happy to help people make good decisions, and with our experience, maybe we've seen something they haven't seen, and we're constantly seeing things that we haven't seen. So it's that's the practice of medicine. So I think you'd find that all these a la carte things are something you got to know how to do.
Absolutely. That's great. Well, thank you, Jeff. Thank you, Neal, so much for joining us today. This was a very insightful discussion. Thank you.
Yeah, fantastic discussion. Especially love going through the history. And I think that's so helpful to always reflect and, hear the stories.
Yes, hear how we got
great.
here, right?
You guys are really, this is the first time
excellent.
I've been involved in something where professionals are doing the podcast. I think it is really, really
You're doing a really good thing.
Thank you.
Yeah.
Thank you so much.
You're digging deep too, which I like.
Yeah.
This is a deep
goal.
dive, and it's not a superficial thing. You guys are digging deep, and I love it.
No, we appreciate it.
That's
I
great.
think there's so much to learn, and it's just sometimes you read a journal article and it's not really telling you the whole story. So getting a little bit more of a long form to talk is really educational, not just, for our listeners, but for us. We enjoyed it as well.
Yeah. Our listeners really want to know what you do, not what's just published. So thank you.
Yep.
Yeah.
And
They're welcome to reach out. Like I said,
you.
tell them to reach out.
And thank you for listening to this episode of the Sports Docs live from the Arthrex Team Physician Controversy Conference. Make sure to subscribe on Apple Podcasts, Spotify, Amazon Music, or wherever you get your podcasts to stay up to date on all things sports medicine.